Thank y'all for coming to this town hall. Gene, Thorn, and I will spend the next half hour trying to give you an update of things that have gone on in Union the last quarter. We always like to start off with an eye care standard. This quarter we're using C for caring. The first three up here are some of the things that the group selected when we were originally doing the eye care standards, and it's treat everyone as if they're the most important person in the facility, respect privacy, and asking the question, is there anything else I can do for you? The real reason we put these up here is so that everybody can kind of think at the time that we're in here. C is for caring. What do I do every day that shows caring to the patients and the visitors that we have at Union Hospital? We also like to go through some of the awards that we've won in the last quarter. Becker's Hospital Review is a hospital trade magazine that they come up with a lot of different rankings. And one of the sets of rankings that they do is 100 great community hospitals. And for the second year in a row, Union is listed on that group, and we're one of 4 hospitals in Ohio that are listed in that top 100. We also received an award from the Ohio Hospital Association, and this one's kind of neat because it's about safety of our workforce. We actually are one of the top 6 hospitals in the state being recognized for having a safe work environment for our employees, and of the size of our size hospital, we actually were the first hospital in there. So that's a neat award to be recognized, and knock on wood that we stay there. And then finally we talk about the mammography area. They got new 3D mammography over there. As part of that, they actually applied to the American College of Radiologists and got recognized as a breast imaging center of excellence. So we're real proud of that group as well. As we go through quality, and you've heard us talk about value-based purchasing, and Gene's going to do a little bit more on value-based purchasing as we get later into the presentation, but the quality monitors that we've been using are changing over the years. And what we're seeing now is hospital-acquired infections are one of those areas that is taking a front row as hospitals compare themselves across the country. The catheter-acquired UTIs, we only had 1 in the last quarter, which is lower than what we've had. And of course, if you look at these numbers up here, we've had in the last year, you've had 9. When we were doing this 3 years ago, there were like 35. So we have made some improvements in there. So even though we still want to get that down to 0, we have made a lot of improvement. Now, the second line up there is central line infections, and the CLAPSIs, we went for over 3 years without seeing any one of them, and we've actually had 2 now in one in the first quarter, 1 in the second quarter. So we put together a team, and they've kind of worked through the process and looked at some different ways to do this so that we can get that back to 0 and keep it there. C. diff's another one that's being monitored. Hospital-acquired pneumonia is being monitored. MRSA, we have one of those that happens to be the same CLAPSI patient. That was the organism that was in that central line infection, so we're working on that. Surgical site infections are up. We don't know if that's up because we're reporting them better, if it was a higher volume of surgeries and it was and the percentage is about the same. But again, we're watching that, and of course we want to continue having no ventilator-acquired pneumonias. We haven't had one of those in about 3 years as well, so we are hoping to keep that number down to 0. The process measures that we used 2 or 3 years ago when we were talking about core measures have changed. These are the ones that are currently being monitored for us, and they've added some ones such as the first line, which is put out there for the obstetricians. You don't want to have any elective admissions or inductions, excuse me, under 39 weeks, and you can see for the last year we've managed to keep that at 0. The vaccine, and the flu vaccine, we don't measure during the summer months, so that one's blacked out. Stroke measures, we got back up to 100%. We've been running at 100%, and then we have that fallout where 1 case falls out, and you can see what that did in the last quarter, but we're back up to 100% now. Time to transfer, the VTE measures, they've been struggling between 95 and 100, can't quite get up to 100. Time to transfer on an AMI, if you remember last quarter, we had one that was pretty high because it was an outlier, an atypical patient presented, and it took them a while before they recognized that this was really a heart attack in process, but we've got it back down in this quarter, back in that 30 to 40 minute range, which of course the national standard is to keep that under 60 minutes. Time to an EKG, we want that under 10 minutes. It's been higher than that. One of the things that we have trouble with is getting the 0 times, and how you get 0 times is that means if they've run an EKG on the ambulance. So when the patient arrives, they've already had the EKG, so it's a 0 time. So we are trying to capture that data better into our system so that we can bring that number down because it looks like we're only capturing those patients who get here without an EKG. And then finally, the long bone pain management has been pretty good for us. The national average is to keep it under 67 minutes. We normally run that 40 to 50 minutes, and we actually were under 40 minutes in the last quarter. So those are some of the process measures that we're looking at. We also monitor hand hygiene. This is something that we started a couple of years ago. We were below the 50th percentile. I think all the hospitals in the country started saying, let's look at washing our hands. We're now up in the lower 90s. Actually, we were at 95% during the month of July. We don't necessarily advertise this one, of course, because we don't want to run around to our friends and neighbors and say we wash our hands 90% of the time, because if you're in a healthcare organization, everybody assumes you wash your hand 100% of the time. So we are trying to get to that number. Let's talk about our service data, the patient experience. HCAHPS is the inpatients, which are looking at our work and they're saying, how are we doing? Our patient experience scores in the second quarter weren't quite as good as we've seen in some of the previous quarters. As you can see, the people who rated us a 9 and 10 fell below the 40th percentile, which is the first time I've seen that in like 3 or 4 years. The people who recommended Union Hospital fell down as well. Communication with nurses were down a little from the previous quarter. Responsiveness of staff was up, so there are some good things in here. Communication with the doctors, the score was up. Hospital environment down a little, pain management up a little, but not as high as we've seen it in the past. Communication with meds and then discharge instructions also hanging in that 30 percentile range. So we have some opportunities in looking at our inpatient world. Some of the other Press Ganey information, we do have an inpatient survey that is Press Ganey that's separate from HCAHPS. That has a lot of the questions that relate to like food service and other areas of the hospital, so there are separate questions. That one's been hanging in that 50th percentile for a while. The ED has an interesting pattern. They always do 2 quarters up, 2 quarters down, 2 quarters up. If we went back, it kind of went that way. So I'm anxious to see actually what the next quarter is going to bring, because they are at the end of that second quarter. Now, in their defense, I know the first week of August they were above the 90th percentile, so hopefully that's going to be real good. Outpatient had taken a dip about a year and a half ago. They've come back up. They were at the 70th percentile when we first started this in 4 or 5 years ago, and they're back at that 70th percentile. First Care has had that sawtooth pattern. They have had 2 good quarters in a row, so I'm hoping that's a new pattern for them. And the ambulatory surgery had been going up. They took a dive last quarter, but are going back up again. So we are seeing a few good things in the patient experience, but more of them are on the outpatient side than the inpatient side. I'm now going to turn this over to Gene and let him talk to you about finances.
Hello, everyone. My name is Gene Thorn. If you don't know me, I think I know most of you in the room. I'm going to actually talk about 4 categories today. The first is our financials, our financial situation, and some of our financial information, and some of the things that will affect our finances in the future. The second is we're going to take a little bit of a look at the ED as a project, and we've got a neat little video, animated video, that shows you what it's like to walk through the ED. Thirdly, we're going to spend some time looking at our new physicians, seeing who they are, introducing you to them. And then fourth thing, we'll talk about the patient portal and some of the new things in the portal that make that kind of a neat little useful tool for us as patients and as a hospital. Looking at the financials for the first 6 months of 2015, we do this every town hall we have, and we just want to give you kind of a quick summary of where we're at financially. And this page actually shows our revenue numbers. We actually ended up the first 6 months of the year with total billings of about $116 million. Unfortunately, we don't get to keep all that, or we don't get to collect all that in cash. You see here, we actually wrote off about $61 million of that amount. That $61 million represents our bad debt, our charity care, some of those things that our third parties just won't pay. And so, unfortunately, that takes us down to a net position of $54.5 million. That actually represents the cash that we collect. for services in the first 6 months. We actually add to that about $2.3 million. This amount is primarily from some non-recurring type revenue sources. You can see it's listed here. It includes our meaningful use monies that we're getting from the federal government. It includes some other special state and federal payments that we receive. And when you add that in, we actually collected about $56.8 million. Okay, as you look, as we keep going on here, how do we spend that amount of money? We have our three categories of expenses here. Salaries and benefits represent the largest expense categories that we have. And our total expenses were $54.4 million. Okay, what that does then, it leaves a net of about $2.4 million, which is generally our profit. Okay, and that's a good thing. We've had a successful 6 months of the year. But as you look back on that previous slide, the special money we're getting, $2.3 million. The profit level that we have, $2.4 million. So essentially, most of our profit is coming from those non-recurring sources. It's reason to be to congratulate ourselves for the success that we've had. But the unfortunate thing about that is that it may not be sustainable into the future if those sources dry up. And that's the concerning financial challenge that we have as we continue to operate as a hospital. Okay, Mr. James talked a little bit about some of our infection rates, our satisfaction scores, and so forth. And the reason that we do that in these town halls is because they really have an impact as we look at the actual payments that we're receiving. And primarily that's because of the value-based purchasing program. Now, if you've been coming to town halls for a number of quarters, number of years, we've been talking about value-based purchasing for a long time. So I'm kind of assuming that everyone knows what value-based purchasing is. A program of the federal government to pay us based on some of our quality results, our outcomes, and so forth. The purpose of this particular slide is to kind of show us the migration or the transition that the value-based purchasing program is actually taking and why it becomes important for us to continue to look at our current operations and some of those results that Mr. James talked about. When value-based purchasing started in fiscal year 2014, we had two categories that the program was based on: our core measures and our HCAP scores, and that was in a 70-30 split here. Okay, and what that meant is that 70% of the amount of impact that we got in federal fiscal year 2014 was based on core measures. 30% of the impact was based on our satisfaction scores. Now, as you kind of move forward to federal fiscal year 2018, we no longer measure core measures. We've added efficiency of care, which is also known as Medicare spend per beneficiary. Basically, Medicare's attempt to kind of look at the total episode of care and the cost related to that and kind of limit the overall cost and the payments made for that episode of care. And they've also included safety of care, infections, complications, those types of things in the calculation. We have an even spread between these four categories in terms of how they impact the overall calculation. And the interesting thing and really the key thing about value-based purchasing in the future is as we look at federal fiscal year 2017, 2018, the measurement period for gathering this type of data is occurring right now. Okay, so what we're doing in terms of our infections, our complications, our Medicare spend per beneficiary, our HCAPs and all that kind of stuff right now is going to be used to generate the financial impact in these future years. That's why we have to pay attention to what this is in the future, and we also have to pay attention to what we're doing right now and try to produce the results that are as good as we possibly can produce. Let's turn now looking at some of our volume statistics, and we're going to go through this relatively quickly. You've seen these, I think, in previous town halls. Start out with admissions and patient days for the first 6 months of the year. Essentially, the trend is downward. It's been downward for a number of years. As you look at most hospitals across the country, their trends in this inpatient area is also down. As we move to some of our outpatient activity, our ED visits, our outpatient visits are actually up a little bit in the first 6 months. We normally have about a 1 to 3 percentage point increase on an annual basis each year in these categories. So that's where some of our growth is coming from. Our surgeries and deliveries, Mr. James mentioned that our surgeries are up slightly. And that's a good thing because our history has been kind of a downward trend on the surgical line. And we've seen that for a number of years. Deliveries is actually up a little bit for the first 6 months, but their volume stays relatively constant on a year-to-year basis. We haven't had much change in our surgical or our delivery business for a while. Before we get into the ED discussion, I think it's pretty appropriate and timely to talk a little bit about some of the strategic issues surrounding the ED and basically everything that we do. We actually built the ED kind of a strategic objective of ours, and a lot of discussion went into that construction. A lot of people basically, well, the cost of the ED first is about $18 million, $17 million. And a lot of people have kind of questioned as to, that's a lot of money. Should we have spent that money elsewhere? Okay? So when you look at those questions and when you look at the answers to those questions, they really kind of represent some of the strategic initiatives and strategic directions that we're creating. Now, healthcare right now is going through a lot of changes, and so strategy, looking at these questions, is fairly significant to us right now, and the questions change a little bit from what they had been in the past. First of all, we have our mission statement. For those of us that have been around long enough, the mission statement used to be on our badges. If you have an old badge, you probably still have the mission statement on there. Sometimes we don't even remember what our mission statement is. But one of the things we currently have to do right now is look at our mission and basically challenge that as to, does that represent our mission for the future? Population health is something that is becoming pretty significant in the way that we provide care to patients. That's changing the environments that we're operating in. And so that certainly is a big topic that kind of is involved in our strategic planning. Probably the big question on here that we're all asking is, are we going to stay independent? I don't know the answer to that, but what I do know is that we all want to stay independent, and we're striving to do that. But many hospitals our size throughout the country is just becoming more and more of a financial struggle or a struggle to basically continue their existence in a lot of different ways. So that continues to be fairly significant for us. And that kind of leads us into, are we going to continue to have the same services in the future? What does that really mean to us? Do we need to drop some services? Are there some that we can add and so forth? And that kind of leads us into, how do we continue to service the needs of the community? The ED was constructed because it basically represents probably the biggest asset to this community in terms of what it means. And that's why the ED became important. So with that in mind, let's now look at the ED and see some of the development and see the animation. First of all, just kind of looking at some of the development of the ED, you've probably seen these as you've been out around the ED construction, but it's kind of taken shape pretty nicely. And you can see from some of these photographs, we've got walls put up, we've got concrete, we've got roofs, we've got some of the site work is being developed around the building and so forth. You can see the walls here. The little cement Zambonis that we have, those things look pretty cool. I'd like to drive one of those, but it's taken shape pretty nicely. The key things, though, about the ED are that the new emergency center, the new building, will actually open in the spring of 2016. But because there's a small piece of the existing building that needs to be remodeled, the completion of the ED won't actually occur until the summer of 2016. And so it's coming up pretty quickly here, so we have something to look forward to. Let's take a look at the animation, and this is as if you're walking through the new ED. So this green dot here basically represents the entranceway into the ED, and the animation is primarily coming in from that point.
You arrive on the lower level, and then you come up to into the ED, because there's a 17-foot drop off from one side of the ED to the other.
When we first saw this video, it was moving pretty quickly, and it almost made you a little dizzy to watch it, so they slowed it down.
There are 38 treatment rooms in the new area, and as you can see, several of them are specialty rooms. We have 23 right now, so you're seeing an increase from 23 treatment areas to 38. There are 4 zones or pods or treatment areas, however you want to look at it, that can be opened or closed at any given time.
The interesting thing about the treatment areas, the 4 treatment areas, are what Bruce just said. We can open them, close them, basically create a little bit of production efficiency in the operation of the ED.
You're flipping around now, and you're going to see the staff stations. There's a lot of storage built into this area, because that's the one thing we never have any place in the hospital is storage. So there's a lot of the middle section of this ED that's a place where equipment, pumps, those sort of things can be placed. There are 2 trauma rooms. Some people think that, we have 4. Are we going down in trauma room sizes? We're really not. A lot of the rooms that we have are larger rooms, so they can kind of function as a trauma room. But 2 realistic trauma rooms is all we really need, given the volumes that we have, and that's even anticipating our volume going up. You're moving over to another zone at this point. You can see some of the trauma rooms over to the side. Behavioral health rooms are designed so that there's nothing in the room so that the patient can harm themselves. I think in a second you'll see a bariatric room. We do realize that we are seeing a lot more patients that are larger, so this room's equipped with equipment to help the nurses move the patient safely so that they are not hurting themselves. And we're off and running again. We just passed, there's a light up above. The rooms themselves do not have any windows in them. All the natural light is in the hallway. You have skylights throughout the hallway, so the staff and the patients will see the lights from that point, but we didn't want to put, for privacy, we didn't want to put any windows in the actual treatment areas. We do have a true isolation room. We redesigned that during the Ebola scare. We realized we didn't have a place that we could dress the staff, so the isolation room has a knockout to the next room so that we can turn the room next to it into a place for people to change clothes. And that's our animation.
So let's now kind of move into our new physicians. We actually have 6 new physicians that have joined us recently, and 5 of them actually have a local connection. We have Dr. Casey Perkowski, who's joining us in family practice, an employee of UPS. He's actually a graduate of, I think it's Dover High School, And so he's come back home to serve the needs of the patients here in Tuscarawas County. Dr. Lindsay Moore is a dermatologist, just recently joined us, and her practice is already busy because there's a great need for dermatologists. Dr. Burgett is joining us in orthopedic surgery. He's also got a local connection. His wife is Dr. Desiato's daughter. You probably know Dr. Desiato, so he's got that connection. And he's employed by UPS, joining East Ohio Ortho. Dr. McGee is actually joining Tri-County Hematology. He's the one of the 6 that doesn't have the local connection that we know of at this point, but it's nice to have him on board. Dr. Henry in podiatry is joining Drs. Myers and Meller, and she is a local girl too. I can't, Claymont. Thank you, Monty. She's a graduate of Claymont High School. And then Dr. Cox is joining us in general surgery, a UPS employee, joining Dr. Zemas and Levitt. And his wife is also a Dover grad. So it's kind of nice to have people that have a connection to the area come back, because the conventional thought in our past practice has been they want to come back to the community so they serve us well and stay and really like setting up their shops here. Finally, let's look a little bit at our patient portal. If you haven't accessed the patient portal, I would encourage you to do so. If you've been a patient at the hospital, it's kind of a convenient way to get some of your medical information, lab, cardiology, radiology reports, ED, first care, physician reports. Those things are all on the portal or will be on the portal. The other thing that's kind of interesting is there's a link to pay your hospital bill on there. And probably most significantly and most current is we would like to move towards patients getting involved in setting up their schedule or setting up their appointment. We haven't set up the module yet that they can actually schedule themselves, but we do have a tool on there that allows them to actually request an appointment, and then we'll get back to them with that request. This is something that we're having to do. The government's kind of forcing us to create these types of portals, but really when you step back and think about it, it's a neat value-added feature to patients about their services from Union Hospital. So it's a good thing for the patients. With that, I'll turn it back over to Mr. James.
Thanks, Gene. One of the things I wanted to kind of bring you up to date on is the WOW program. You're going to get some information from the WOW team, but we're changing the way we've done this. In the past, we've given you cash incentives against your premium. They're going to stop that because we have not seen any change in the health care across the organization. However, if you go down here at the bottom, there are going to be opportunities to win some additional PTO out of that. Lab work, the strategic health services, coaching, all of that, we will continue to have that. But we will also have a few more pieces of that. Please continue to follow along with what the publications are coming out from the WOW group. A couple of miscellaneous things. We are going to metric and weigh in our patients. The Relay for Life team did their work in the last quarter. They raised a little over $4,900. And normally I have pictures of the DASCO picnic, but since we moved it inside in the rain, I don't have pictures of it, but I did want to recognize that DASCO does do that for us, so I put it in there. Had a couple of retirements. Charlie DeMuth retired. Most people know Charlie. This was his second career. Most people remember him as the commander of the State Patrol Station. Pam, on the other hand, had been here for 34 years when she retired a couple of weeks ago. This is one of the leadership development programs. We do this a few times a year where we take the leaders off site to do some educational work, but we also want to be recognized not only as a community asset, which Union Hospital is, we also want to be recognized as providing some help into the community. So we actually went out and spent about half a day cleaning up Shunburn Village in the spring before they opened up. So in summary, we are proud to be recognized for the things that we were recognized during the past quarter. Our quality data is slightly better. Our patient experience data has an opportunity to improve. Hospital finances are looking pretty good, but as Gene told you, they are a lot of one-time money in there. Value-based purchasing is changing, and we are now 2 years ahead or behind, whichever way you want to look at it. How we're going to get paid in 2 years is what's happening now. Inpatient volume continues to decline while outpatient volume continues to grow. That's sort of what you'll hear from every community-based hospital, and it's sort of the purpose behind the ACA. Watch for the changes coming in the WOW program, and our future includes not only a new ED but several new physicians that we've had. And with that, does anybody have any questions?